Colleagues and friends, welcome to 1 year on the pervasive health challenges in Afghanistan, to session 2, which is focused on the Sehat, or health of women and children in Afghanistan, challenges and solutions. My name is Dr. Nadia Aksir. I'm a scientist at Johns Hopkins University, and I will be the moderator for the session. Next slide, thank you. In terms of run of show for the hour together, we'll spend about 5 minutes giving an introduction and background on the topic, and then we'll move right into a structured dialogue for about 30 minutes with our esteemed panelists. After that, we will have a Q&A for 20 minutes and direct questions to each of our panelists. And finally, we will wrap up for the last 5 minutes. Just a few reminders for the webinar. You are welcome to put your introductions in the chat, but please do put any questions you might have for our panelists into the Q&A feature, which is separate from the chat. So please use the Q&A feature because we will collate the questions from there. We will try to answer as many of your questions as possible during the session, but apologies in advance if we don't have time to get to all of them. We will be recording the session and sending out the recording after the fact, and we will be translating it to local languages, Pashto and Dari, so please do look out for that. And finally, please do join us for the remaining 2 sessions in the series, on one focused on nutrition and the other on sustainable development goals in Afghanistan. My colleague will put the link in the chat. You're welcome to click there and to sign up if you haven't already. A little bit of background. Despite pervasive poverty and ongoing instability, Afghanistan made remarkable gains in health development and access to essential reproductive, maternal, newborn, and child health services, RMNCH, over 2001 to 2021, over the past 20 years. Maternal mortality, just some indicators here, maternal mortality dropped almost 60% from 1,450 to 638 deaths per 100,000 live births over that window. Under 5 mortality declined by more than 50%, and adolescent fertility also dropped about 60%, among a range of other outcomes that improved in this window. In terms of essential interventions that contributed to that progress, I wanted to show you this figure here, which shows the composite coverage index. That is a weighted average of 8 essential RMNCH interventions that are listed there: family planning, ANC, antenatal care, skilled birth attendance, 3 vaccines for children, BCG, 3 doses of DPT and measles vaccination, and oral rehydration with continued feeding for diarrhea, treatment and care seeking for acute respiratory infection. A composite score of these essential interventions has been published in the literature, and it's called the CCI. The figure on the right shows you the CCI across the country in Afghanistan by province over time. The blue dot indicates the estimate of the CCI in 2003, the black dot indicates the level in 2010, and the orange dot indicates the level in 2018. Across the bottom, you see the percent coverage of CCI. Higher values are better, indicating that more of the population is covered by these essential interventions. What you can immediately see from this figure is that there are big gaps between the blue dot and the black dot in most of the provinces in Afghanistan. And this is actually a good thing. This shows that the coverage of the CCI, or access of families to these essential interventions, has increased dramatically from 2003 to 2010. For instance, take Bamyan. We see the blue dot is at about 23% or so in 2003, and this increased to 45% in 2010. So a huge increase in the coverage of the CCI just in that short 7-year window. By 2018, there was slower progress, but there continued to be progress. And this progress is evident across the country in Afghanistan. One thing to take away from here is that Afghanistan, across its complex geographies and populations, is making progress and had been making progress in improving access to essential RMNCH services over the past 20 years. Next slide, please. What are some of the key drivers? There are many drivers that have been published, but I wanted to flag a few here for you. Most notably, the basic package of health services and essential package of hospital services that were delivered through NGOs in Afghanistan have been critical to the gains. And of course, because this ensured that RMNCH services became more available and accessible in the facility and also the community. Despite the progress, issues around quality of care remained, but progress was made. Many innovations to extend services to remote and isolated populations or white areas were also piloted and successful in Afghanistan to varying degrees. This included mobile health teams, family health houses, maternity waiting homes, results-based financing, e-health, and many other innovations. There have also been major improvements in training and deployment of nurses, doctors, and midwives over that window, 2001 to 2021 in Afghanistan, which has been pivotal to the gains that have been made in health. Of course, nothing is possible without investments in high quality data, and Afghanistan did much of that, investing in large scale services, a strong health management and information system, among other platforms as well, and use that data effectively for decision making, even at the most local level. There have been major improvements in women's education and literacy and empowerment, which is our underlying drivers for many of the gains that have been made in maternal and child health. And of course, there are many other success factors that we don't have time to get into in this short window, but are notable and are published. Next slide, please. So what is happening today? In the past 1 year, many things changed in Afghanistan. And with that, the population dynamics and the burden of disease profile has changed as well. Over 24 million Afghans today are in need of humanitarian assistance, of whom over 18 million require immediate health care. Those needing life-saving care include 3.2 million children under the age of 5 and some 350,000 pregnant women. Maternal mortality is on the rise, and according to one estimate, the maternal mortality ratio might increase by 50% from that number that I showed earlier, 638, to over 963 deaths per 100,000 live births by 2025, unless there is severe intervention. Many pregnant women remain vulnerable because of relatively low access to antenatal care, postnatal care, and skilled attendance at delivery. And it's estimated that 20% of deliveries and newborns require life-saving emergency interventions, yet these are not readily accessible to most women because of restrictions on mobility, limited capacity of providers, and weak referral systems, among other challenges. It's also estimated that unmet need for family planning could increase to almost 40%, and about 4.8 million unintended pregnancies could occur by 2025. And of course, this is coupled with multiple disease outbreaks, including COVID-19, acute watery diarrhea, leishmaniasis, malaria, and scabies. Colleagues and friends, to discuss these issues and challenges and potential solutions to support and protect the Sehat, or health of women and children in Afghanistan, we have brought together a group of esteemed global experts to share their views and ideas with us today. These experts represent the donor community, WHO, Afghan diaspora, and scholars. I would like to take a minute to introduce our panelists for the session. First, we are joined with Dr. Katie Todd. Dr. Todd is an obstetrician, gynecologist, and epidemiologist who started working in Afghanistan in 2003. She has almost 20 years of experience leading research and programming in family planning, maternal health, child nutrition, infectious diseases, and substance use. You may be interested to know that Dr. Todd is in fact one of the most published scholars on health in Afghanistan. We're also joined today by Dr. Pata Shikvayadze. Dr. Pata is currently the RMNCAH and GER Programs Coordinator at WHO. He holds an MD in surgery and PhD in obstetrics and gynecology and an MPH in health policy administration and behavior change communication. He has over 22 years of experience in planning and administering public health, health service delivery, and health promotion programs in development and humanitarian settings, and since December 2012, for about 10 years, has been coordinating and leading RMNCAH and Gender Equity and Rights GER programming at WHO Afghanistan. We are also joined today by Dr. Farzana Maroof. Dr. Maroof has worked previously for many of the big players in health in Afghanistan, including UNICEF, the World Bank, and most recently she was with USAID, where she was a senior health specialist. She holds a Master of Science degree in health policy and strategic management and a PhD in reproductive and maternal health. She has over 18 years of experience working on RMNCH health system strengthening, quality of care, and capacity development of health workers in Afghanistan. And last but not least, we are joined by Dr. Saifatullah Habib. Dr. Habib is a senior program manager for health and nutrition at the European delegation to Afghanistan. He has an MD and MPH and over 30 years of experience working in public healthcare systems with an emphasis on child health, reproductive health, mental health, health reform, decentralization, and community-based services in Afghanistan. He has worked with the EU delegation to Afghanistan for 11 years in various roles and is presently in a very senior program management role. Colleagues, let's take this time now to get right into a structured dialogue with our panelists. Just a few notes before we get into the dialogue. The participant responses will be timed per the timing that we showed in the agenda slide. There will be a timer that's pinned to the screen and it will ring when the timer is up. When the timer is up, we move on to the next panelist. And we are trying to strictly stick to these allotted times so that we can make it through the entire agenda. So let us get started. Okay, so I'm going to hand the mic over to Dr. Farzana Maroof, who's going to start us off telling us a bit about what is going on with women's mobility and empowerment on the ground in Afghanistan right now. Dr. Maroof, over to you.
Thank you, Dr. Nadia. It is an honor to speak in this webinar. I will elaborate on the women's issue from both the client or right holders and the healthcare or frontline perspective. As we all know, in Afghanistan, there are critical concerns on women's autonomy and decision-making power, restricted mobility, and the obligation to have a male chaperone, the social exclusions and marginalization. Women have low education level and high unemployment rate and suffer from lack of income and financial constraint. For instance, their inability to pay for transport to visit the health facility. Also, there are inequitable spousal relationships and power dynamics with the family, within the family, lack of control over resources that leads to gender-based violence and discrimination. We are also aware of the tradition of early child marriage and adolescent pregnancy and high preference for male children or having boys in the families. These all shape beliefs and behaviors in Afghanistan, and the most vulnerable population, usually we are talking about poor, pregnant, and powerless women, they face barriers accessing to healthcare. For instance, in urban settings, this leads to underutilization and undervalue of primary and secondary healthcare facilities due to the poor quality of care, and primary health seekers overburden the tertiary care facilities. Also, in rural areas, men are the primary income earners, and women's contribution at the household level is not highly valued. This often results in male-dominated decision-making, including health-seeking and food-related purchase. Also, women have low awareness of healthy behaviors and healthcare seekings of RMNCH, tuberculosis, EPI, nutrition services, and this contribute to the high level of maternal and newborn complications, and lastly, high mortality and morbidity. And from the frontline perspectives, we know that the women comprise the vast majority of frontline health workers, and especially in maternity care, including the midwives, female doctors, and community health workers. And we know that currently female health service providers face additional challenges in providing the quality of care and quality services, including their lack of safety and well-being. In most instances, healthcare providers are traumatized, and it's not easy for the traumatized cadre to provide compassionate and respectful care. We are also aware of the current sex disaggregated policy on visiting and treatment of the patient, and also the lack of the healthcare workers in various disciplines and fields. Also, there are impediments to leadership and career advancement opportunities for female, and we know that power imbalances exist in the workforce.
Thank you, Dr. Maroof. You've raised many important issues that are problems on the ground right now. I'm going to hand the mic over to Dr. Pata, who is going to share with us some ideas and solutions from the WHO perspective on some of the issues you've raised. Dr. Pata, over to you.
Thank you very much, Dr. Farzana, Dr. Aksir. My warm greetings to distinguished panel and to all our viewers. Greetings to all of you. Indeed, female mobility, independence in decision-making, social roles, access to education and work opportunities have been directly impacted historically in Afghanistan, specifically by the conflict and the war of more than 4 decades. This had a very negative effect on the female life, including on the literacy rate, which is very low, estimated at around 16% by 2015. In addition to this, the current authorities have imposed additional restrictions on females, on women, in terms of restricting them to travel more than 72 kilometers without mahram, not opening the schools since last spring from grade 6 and higher, also imposing restrictions on women travel by air, domestically or international, without mahram again, and imposing separate access for, meaning separate days of accessing recreational parks in the cities, separate for women, separate for men. Well, this is negative, of course, and it has its impact on access, free access for the healthcare workers as well. They cannot freely access, meaning they have sort of restrictions or troubles accessing their duties at health facilities. It also impacts their mental health for sustaining or even improving the quality of health services. Their situation is complex. There are no direct or easy solutions. I would suggest that if one will think of single most important move to make, that will be urgently reopening the schools at grade 6 and above, and continuing investments into the education at all levels. This will ensure that high school graduates will have education to start entering medical professional education at medical schools and midwifery schools. Thank you.
Thank you, Dr. Pata. I'm going to hand the mic over to Dr. Todd, who is going to continue reflections on this topic.
Okay, thank you very much, Dr. Nadia, and thank you, Dr. Pata, for those excellent observations. I would like to first thank my colleague and friend, Dr. Farouk Mansour, for some of the insights and information that helped shape this presentation, as well as inputs from some other colleagues and friends. And so nice to see so many of you here today on this webinar. So with regard to solutions to some of these very difficult challenges that Dr. Farzana and Dr. Pata have outlined so well for us, I'd like to look at this through the lens of women as and their families as health service consumers. So first of all, a potential solution and area for focus would be engaging leadership, both at very high levels via donors and foreign governments with their Afghan government counterparts to discuss the need for building in greater flexibility in women's autonomy, travel, and consent as potentially requirements for funding, and also to emphasize the economic benefits of doing so. It's also important to consider grassroots level leadership, potentially through community and religious leaders, to talk about ways to negotiate better transportation and safe passage for women, both as healthcare providers, as well as patients and mothers for their children. A second area of consideration is developing household level planning interventions. Initially, these would be gender accommodative and would focus on the male head of household, with emphasis on planning in advance for healthcare expenditures and making a plan for what happens when women go into labor, or what happens when your child is due for a pentavalent vaccine, for example. Over time, these would shift to becoming gender transformative interventions. We know from data from 2019 that at least half of households already have collaborative decision-making between husbands and wives for health. So we think that this is something that could potentially be acceptable and highly desirable for couples-based problem solving. Thank you.
Thank you, Dr. Todd and Dr. Pazza and Dr. Farzana for starting us off with these really important issues. Let's move on to something that's very much related. Of course, these restrictions on women and their mobility and empowerment is going to have an effect on the availability and the health of female healthcare workers in Afghanistan. And we know in the Afghan context, it's very important for a female to treat a female. So these are pivotal to maternal and child health. So let's hear from Dr. Habib on how this is affecting female healthcare workers and the subsequent effect on quality of care and maternal and child outcomes. Dr. Habib, over to you.
Greeting to panel member and also those are online, and good morning and good evening. And shortage of female health worker is one of the main challenges. Afghanistan has faces a serious shortage of female health worker. At the national level, only 30% of health workers are female, but the density of the female health workers are much low at the provincial level to compare with the big cities in capital. For example, based on the recent HMIS information, 22% of MD, 18% of nurses, and only 7% of community health supervisors are female. This percentage is further below at the district in the remote area. And the main reason for low percentage of female health worker is at the national level is low number of female at the pre-service education in the primary and the secondary and the higher level education, and also at the mid-level education institute who are responsible to for the training of a specific cadre for the health services. If constraint and ban on the secondary education on girls continue, this percentage will further go down. And also this shortage of at the remote level, the main reason is because of the lack of opportunity for the career development, no proper accommodation, no proper education facility, ongoing insecurity, and also competition from the private sector. These are the main reason for the shortage in the remote area. And also this shortage of female health worker is the major constraint in access and utilization of health services in the cultural context where male health worker cannot provide key and essential services to mother, children, including nutrition. And nutrition services, and also limitation on the movement of female health worker, further limited providing of services through mobile health services in the remote area to mother and children, and also outreach activity like psychosocial counselor, nutrition counseling, and other activity. And putting condition as a mahram for the female clients, further limited access of mother and also child to health services. And the data from the last household survey shows the low utilization of key services by mother and children. For example, family planning, contraceptive prevalence rate is 20%, first ENC is 59, while the 4 recommended ENC is only 21%. Full immunization of children under 2 years is 61%, and also scale birth attendance is 58%.
Thank you, Dr. Habib. Many important issues that you've raised. I'm going to hand the mic over to Dr. Pata, who is on the ground as we speak in Kabul, dealing with many of these issues in the communities. Dr. Pata, over to you for any ideas or solutions for the issues Dr. Habib has raised.
Thank you. Thank you, Dr. Habib. Very interesting data. Fully agree. Look, let me start by a few statistics also to reshape this dialogue. The latest HMIS data, corroborated by WHO program data and by also the third party, indicates that 34% of the total workforce in public health sector in Afghanistan are females. However, on the other hand, 74% of all public health services are given to women and girls. So you can see the discrepancy between the demand and the supply side. In addition, 40%, more than 40% of deliveries are happening still at home, assisted by either traditional birth attendants or community health workers. So even at the household level, we have very limited health workforce of females. Solutions could be many different, but of course limited by the limiting funding. Let me start by saying that there is a need to ensure and sustain availability of at least one healthcare worker, female healthcare worker at the the primary healthcare level, by providing incentives for transportation, including for mahrams, especially during deployments in suburban and hard-to-reach areas. We already spoke about urgent importance of reopening the girls' schools. This is very important, not only for the health sector, but also for the whole development of the country. I would also emphasize the importance of scaling up the practice of Kabul Medical University for the pre-service training in BMONG, IMCI, and family planning, which WHO has been sponsoring since 2017. So scaling up this practice across other key regional medical universities will be very important. And finally, maybe if time allows me to say, inclusion of psychosocial support and resilience training within the midwifery and medical schools will be also very important to prepare graduates for the shocks and stresses that they may experience in their work life.
Thank you, Dr. Pata. Some excellent context-relevant solutions that have been raised. I'm going to hand the mic over to Dr. Todd to add to that. Dr. Todd, over to you.
Okay, thank you very much, Dr. Habib and Dr. Pata. Those were excellent points. And to take on from some of the points that Dr. Pata made about pre-service education, a number of these considerations need to also extend to in-service programming, particularly ongoing support for resilience and psychosocial support for providers who are now being confronted with increasing challenges on top of very high patient volumes and not having enough providers within each facility. Another consideration that Dr. Pata also touched on is the need for adapting employment packages to accommodate the needs of women, including employment for their madam, so that it's actually feasible for female healthcare providers to go to the different care sites and stay there for a long period of time to help prevent turnover. There also needs to be greater consideration of home-based care models, home-based provider models. Dr. Farzana mentioned the family health houses, and so did Dr. Nadia. There's also the Kana Kabbalah model. And those should be reevaluated within the current context to see whether or not those models afford the ability for women both to access care as well as freely provide care, since those clinics are based out of their homes. This also positions women as the sole providers in these clinics, and ongoing support for business development skills, as well as support to them for supply chain and other routine needs as solo providers will also need to be considered. Last, there also needs to be greater exploration of task shifting. I know that we talked about traditional birth attendants and community health workers, but it remains an open question in the current context of how active female community health workers are, and whether there are opportunities to use care extension models that progressively task shift some tasks to lay providers to help ease the healthcare worker shortage. Thank you.
Thank you, Dr. Todd. Some really important solutions and ideas raised there. I'm actually going to hand the mic back over to you. You touched a little bit on, and you were alluding to the need to start adapting the current service delivery interventions and models to the context that we have on the ground. So I'm going to hand the mic back over to you to tell us a bit more about what kind of adaptations do you think are possible of the essential services for RMNCH in this current context?
Okay, thank you very much, Dr. Nadia. So I think, to be fair, first of all, this is being structured as a challenge. It's not really possible to say what may and may not be possible to do in this context. And these are just some ideas, but first of all, I want to acknowledge just how incredible the challenges have been, as well as the stories that we're hearing of the incredible commitment demonstrated by midwives, female doctors, and others within the care system in Afghanistan now, trying to make sure that a standard of care is maintained. So first of all, a quick salute to them. In considering some of these challenges, I think there are two ways to look at this that are important. So first of all, how can we ensure that we preserve the successes of the last 20 years? So the evidence that was presented at the beginning of this webinar talked about some of the successes that have been achieved in Afghanistan. And a lot of this comes down to developing a health system with strong leadership and governance and good policies through BPHS and EPHS packages. So the first and probably the most formidable challenge will be how to sustain the current BPHS and EPHS system. And this should be the primary focus for this particular area. Within those packages, a number of the challenges that have been mentioned tonight have been exacerbated in the last 2 years, but these challenges have been present for the last 2 decades, possibly longer. And in thinking about how to improve care while still contending with relatively low numbers of healthcare workers, female healthcare workers, and maldistribution, looking into abilities to include self-care approaches, as well as investing in high impact interventions such as misoprostol and chlorhexidine. So the question is, for some of these promising interventions that were pilot tested in the past, how can those be rapidly scaled up? And how can considerations be made to make these more self-care oriented so that women are able to use these in the privacy of their homes if they're unable to reach care? And then last, also how to sustain in an emergency situation, comprehensive emergency obstetric and newborn care services, as well as IMCI services for pediatric emergencies. The other way to look at this is also, how do we adapt to the current context? Should we reconsider the 3 delays through a different lens? What are the new ways to look at the delays for decision-making, for destination, and then for care delivery at site? So I think that there are a lot of opportunities for community-led solutions and advocacy, but I hand over that challenge for my colleagues to comment on. Thank you.
Thank you, Dr. Todd. And I'm going to hand right over to Dr. Maroof to start us off with some ideas and solutions for the issues you've raised. Dr. Maroof, over to you.
Thank you, Dr. Nadia. As all my colleagues pointed out, Afghanistan has a prioritized package of services, and more than 50% of the priorities evolve around ORMNCH, including the well-established community-based structures, which is a good opportunity, and introduction of the high-impact intervention and self-care and other innovative approaches that Dr. Pata and Dr. Todd mentioned previously. But we all know that the health system is quite underfunded. Always funding is a challenge. But this is so important that embed the scale up and implementation of the self-care, high impact, evidence-based and low cost interventions in the current systems, including use of tech solution or some of the technology solutions that currently many projects like MSH, JPIGO, and other partners are implementing in Afghanistan. And also strengthening service delivery and improving the availability of supplies and commodities that Dr. Todd also mentioned, because of the introduction of misoprostol or subcutaneous DMPA that we also call it the Cyanopress. There is nothing about the misconceptions that was very well accepted by the community, but the main challenge was the availability of the commodity or supply in Afghanistan. So, and the role of the private sector and social marketing organizations that currently the Shops Plus, LHSs, and many other partners are doing, this is so important that private sector plays an important role to leverage the expertise, access to people, technology, distribution networks, and more to save the lives and build resilience. Also, Dr. Todd was mentioning about community participation and awareness, engaging individuals, families, and households in nurturing care and also in social behavior child communications. And lastly, I would say that collaboration between the humanitarian and development actors is a must. The alignment and harmonization of resources to collectively respond with the shared visions to the current problems and challenges that we suffer.
Thank you, Dr. Maroof, and a nice lead into Dr. Habib, who in fact is from a donor agency who is providing to Afghanistan. Dr. Habib, we will hand over the mic to you to respond to some of the ideas and issues that are raised.
Okay, thank you, colleague, for the panel members for the raising very good points, challenges, and also solutions. And from the financial perspective, and also the donor provide fund to the BPHs and EPHs through ERTF, through Bullet Fund, and the fund for at least 2 years is available for the implementation of BPHs and EPHs under Health Emergency Response Project. And this is the essential and basic services, one of the key priority area for the donor. And this all the essential services like IMCI, EPI, and family planning, other are part of the BPHs and part of the EPHs and BPHs. Some of the innovation piloted and with expectation to be extended based on the positive result. But after the political change in last year, the main focus is on the continuation of basic and essential services to the needy population of Afghanistan. But still, it is possible to pilot to some of the high impact intervention within the scope of the BPHs in EPHs under the current contract. For example, distribution of misoprostol through community-based intervention for the prevention of post-hemorrhage through community health worker, and also to increase awareness of the community for recognition and making decision with the engagement of CHW to identify the pregnant women and to encourage them, and also to improve referral by improving communication between the community and between the health facility and different level of health facility, and also providing transport. Use of technology, for example, mobile team, and using of traditional transport, and also ambulances between to prevent delay in starting treatment of those who are in need of emergency care.
Thank you, Dr. Habib, and thank you, Dr. Maroof and Dr. Todd, for taking us through the journey with adapting these essential services to the local context, or to the current context. We're going to shift the conversation a little bit now to talk about data. Nothing is possible without data, so we can measure, monitor, and benchmark our progress and know whether we're making gains or not. So I'm going to hand over the mic to Dr. Pata, who's going to walk us through some of the challenges when it comes to data in Afghanistan.
Thank you, Dr. Aksher. A very good discussion, and I'm very happy that I can bring another dimension of data and health informations to this panel. As during past 2 decades, various donors and partners have provided significant technical and financial support for establishment and sustaining health information systems in Afghanistan. Those systems are diverse and composed of routine service reporting systems and reporting systems of special programs based on the DHIS2 platform, National Disease Surveillance and Response System, the data support for administrative system, including for human resources, financial management, supply management, health facility assessments, and also various household surveys have been sponsored and supported in the country. These data sources were providing fairly sufficient information for planning and costing BPHS, EPHS packages under the Sehat Public Health Program. The 2 major concerns at the time were how to continuously improve the data quality, the data management, and how to integrate and sustain culture of evidence-based or evidence-informed decision-making at national and subnational levels. However, with the pause by donors in developing funding, there is serious concern in sustaining functionality of even routine HMIS and NDSR systems. Now, zooming into maternal child health, we all are well aware of effective evidence-based interventions to prevent and treat maternal and perinatal complications, which have proven very effective in reducing preventable maternal and newborn deaths. Nevertheless, accurate health information detailing of how many mothers and newborns died, where they died, why they died, is essential to understand and take action for eliminating such preventable death. The maternal and perinatal death surveillance and response process, MPDSR as we call it, promotes routine identification and timely notification of maternal and newborn deaths. It provides continuous surveillance and links health information system with the health response by guiding service quality improvement processes from local to national level. The challenge is to scaling up nascent existent MPDSR program under the absence of development funds. Thank you.
Thank you, Dr. Pata. To respond to some of the issues that you've raised, I'm going to hand over the mic to Dr. Maroof, who will share some ideas and solutions from her perspective. Dr. Maroof, over to you.
Thank you, Dr. Nadia. As we all know, most of the reported maternal newborn deaths are preventable, with the leading causes of hemorrhage, hypertensive disorder, sepsis, and for newborns, prematurity and low birth weight, with timely and appropriate actions. So as also we discussed, some of the home birth and private sector data usually doesn't streamline in the HMIS. This is also a portion that left behind from the MPDSR. So this is so important to prioritize the scale-up implementation and institutionalization of MPDSR at the national and subnational level. As Dr. Pata mentioned, the program didn't establish to a well-national program to improve the reporting and response enough. And also establishment of MPDSR data for real-time data collection and management, and integration of the MPDSR with the current disease surveillance system, because MPDSR is always implemented as a vertical in silos, no integration of the system, and the DHIs too. So this is something that further could be considered for improving the routine availability of routine data, and inclusion of the stillbirth. This is also so important. And lastly, the linkages with the community interventions, and also improving with the improving of the verbal autopsy, and also improving the social accountability and response. There were some small projects by provincial association that were piloted on the verbal autopsy, but the small pilots worked so well, it didn't turn to a national program to improve the maternal and newborn death responding. And lastly, we cannot improve the reporting and response without investment in the CRVS system. It also needs due consideration to improve the system.
Thank you, Dr. Maroof. Excellent, right on time. So I'm going to hand the mic over finally to Dr. Habib, who's going to share his ideas and solutions on this topic as well. Dr. Habib, over to you.
As Dr. Pata has already indicated, Afghanistan is one of in data-rich country. We have we have tools for routine data collection, and also we have household surveys, which is and also to collect the information on the impact and also on the outcome level. And also the main challenge in Afghanistan is the utilization of the data at the national, at the ground level, and also how to improve the capacity of the local at the ground level of the health facility staff to utilize the data for improvement of health services for their catchment population. And also mix will be conducted this year in a household survey is planned for the next year. And also this is one of the main issues. Some of the data collection are going in parallel. So they are not integrated to the national data system with the DHIs, with the HMIs. This is one very important to integrate all those vertical data collecting system with the national tool that will contribute to sustainability of the of that specific areas. In addition to that, and vital statistic was initiated before August 2021. It is still in functional at the national and also at the subnational level. It is possible to expand to the community level to, for example, as Dr. Farzana mentioned, wearable autopsy to expand to the community level by engagement of midwife and also the female doctor from near health facilities. This is and also it's possible to do within the scope of the current BPHS contract.
Thank you, Dr. Habib, and all other colleagues for all your valuable insights, perspectives, ideas, and solutions that you've raised. We have about 13 minutes left in the session, so I'm going to move right into the Q&A. We have some great questions that have come into the chat, so I'm going to direct questions to our panelists, and we'll put 1 minute on the clock to respond. Dr. Maroof, I'm going to have the first question for you. This is 3 questions rolled into one question, since they're all related. So the question is about midwives. In the past 10 years, about 6,000 midwives and community health nurses have been trained and introduced to the healthcare system. There have also been midwives that have been trained by the private sector. The question is there any figure for how many of these midwives have left the country? And how many of them are currently remaining? And what is the scope for how these midwives can contribute to primary healthcare in Afghanistan, including from the private sector?
Yeah, thank you, Dr. Nadia. This is an important question regarding the figures and data. So as this is true that many of the midwives have left the country, there aren't any exact figure available, but partners are working on mapping of the HRH, Human Resource for Health. So hopefully we will have some figures in the near future. But this is true that private sector played a critical role in increasing the human resource in Afghanistan, including the midwifery education. And the recent UNFP report shows that now there were even recently like 30,000 midwives in the country. We are aware of the transition and turnovers all over in Afghanistan, but now the issue is more on their skill and capacity, not only for the midwives, for the community health workers, for the female doctors. Their skill building is a big issue. So to improve the quality of their education training and also their employment. And the second part of the question, I will elaborate quickly. So luckily in Afghanistan, the midwife scope of work is allows that they should practice the BMONC on all signal functions, and they play a critical role in improving the primary health care, especially at the community and facility level. Over.
Thank you, Dr. Maroof. My next question is for Dr. Pata. Dr. Pata, the audience is wondering, do issues arise from different remuneration for local healthcare workers in programs that are supported by international donors or the NGOs that you work with directly? So the remuneration and that varying across individuals who may have the same skill or same training, does that happen on the ground, and what are some of those issues?
Thank you for the question. I think the problems with remuneration for Sehat money services, there's a scale in the country level which has been established since the previous government, and the current government also maintains the same scale. When WHO and UNICEF, we were sponsoring Sehat money implementation since last November, we didn't see any changes in the remuneration of health services or health service providers. And we were strictly sticking through the NGOs. We were strictly sticking to the scale that has been provided by the standards. There was some deficiency or some calibration in the actual revenues that health service providers were receiving during first three months from December to end of February, when AF has been devaluated, but then it quickly reshaped, regained its value, and no changes were applied. Thank you.
Thank you, Dr. Pata. I have a question for Dr. Habib. So Dr. Habib, colleagues are wondering, this has to do with immunization, but after the regime change, what specific facilitators and barriers for overall EPI and polio programs have you seen that impact the immunization coverage in the country?
Yeah. The immunization in the funding level remains, there is no decline in the funding level for the immunization and for the polio program, and also the EU support through bilateral through the polio, and also through the through headquarters, through Global Fund, and also through Gavi. The fund is available for the immunization, and also there is the main issue is how to improve coordination between the routine immunization, between the polio campaigns, because they how to improve coordination, have to complement these two programs to be complementary to each other, and also some of the to tackle those challenges which currently the national NID program is facing. For example, how to go back to house campaign. Now it's mask to mask campaign. Over.
Thank you, Dr. Habib. I have a question for Dr. Todd. Some of the audience members are wondering, what are the opportunities to work collaboratively with humanitarian actors to accelerate and scale up some of the high impact self-care interventions that you were mentioning at the community level?
Okay, thank you very much for that question. And I think that potential collaboration presents a lot of advantages for the humanitarian actors. Because of the shorter duration of funding, there is a lot more communication and collaboration, and they're also working with smaller populations at one time more intensively. So it creates, in some ways, and forgive me for saying this as a researcher, an ideal setting in which to try new innovations and rapidly produce data on whether or not they're going to be successful. So I think that this presents a great opportunity to look at potential opportunities for novel ways to distribute and stabilize supply chains around cyanopress, for example, for family planning use, or to test community health worker provided care as a way of task shifting. However, one caveat I would put with this is that in these smaller settings, issues that don't usually show up until an intervention is taken to greater scale, such as supply chain constraints, may be underestimated. And these are really important to consider as something is progressively taken to scale and transitioned from a smaller edge of working innovations in a humanitarian setting, is that there may be a diffusion of innovations because these populations tend to be transient. People may be able to go back to the areas where they originated from, to their homesteads, or set up new homes and communities. And innovations that are learned in these settings can be easily disseminated to these new communities or when people go back to their provinces of origin. Thank you.
Thank you, Dr. Todd. Dr. Maroof, a question to you. A broader question here. Do you find it difficult to work in the area of public health in Afghanistan when there are many misconceptions that the country is unsalvageable or a lost cause? What are your thoughts?
I think it is not easy to perform. We know that things are becoming more difficult for both, as I mentioned, for frontline health workers, for policymakers, for public health experts. And at the same time, we are hearing, and we also alluded a lot on the issues around the woman, their health-seeking behaviors, their unemployment, lack of income. I think it is not easy. Things are not getting easier for everybody. So I think that despite everything, we all need to be very innovative, and still the women and children, they need health services. And so we appreciate the frontline health workers and also all the women there in Afghanistan. But I feel it is not easy to perform any type of the duties in Afghanistan. So I provided a general response.
Very, very diplomatic general response. We like that. Dr. Pata, question for you. I think this is sort of underpinning the entire discussion here. But can you shed some light for us on what is the current status of funding for BPHS and EPHS? And what additional terms may be included or might be included in the future that may affect RMNCH?
I think the funding is potentially available from the ARTF, World Bank, sponsored by more than 35 countries. This HER project, as Dr. Habib mentioned, Health Emergency Response Project, supposed to be started, I think, 1 week ago. But still, the contract, there is a negotiation going on between the government and between the NGOs and between the donors, partners on the when and how to initiate the services, because there has been a dialogue and they are studying the results of the previous implementation, and this dialogue is still continuing. Currently, services are provided. Now, in terms of specifically what will be the change for RMNCH, at this stage till 2023, no changes are envisioned. Services will provide through the same package. However, I think donors and partners will start reinvigorating discussions on the integrating essential package of services, which was almost finalized in 2021, but never materialized. Over to you.
Great, thank you, Dr. Pata. So we have 1 minute remaining in this session. I'm going to take the opportunity now to close down our session. I want to thank our panelists very, very much for their valuable time, expertise, and experience and sharing that with us on this platform today. Thank you very, very much. I want to thank the audience for joining, for being engaged and asking great questions. Thank you very much. Apologies if we didn't get to all your questions, but hopefully we shed some light on some of the issues and questions that were on your mind. Just a few closing reminders. Please do visit our Mission Afghanistan 2030 Johns Hopkins page for more information on upcoming sessions and other activities that are ongoing with regards to health in Afghanistan. We will email out the session recording after it's translated, so do look out for that and feel free to share it out in your networks. And do please join us for the remaining sessions on nutrition, which will be in 2 weeks. And then the final session on the Sustainable Development Goals in Afghanistan, which is a special 2-hour session that we will have with 6 panelists representing diverse donor agencies, UNDP, and other Afghan experts. So we look forward to seeing you there. And again, thank you very much for joining us. And thank you to our panelists. And thank you to the organizing committee, Brittany and Sama, who've been pivotal in this work. Thanks again. Have a great day. And we look forward to seeing you in our next session. Bye-bye.
Thank you very much all.
Bye.
Stay safe.
Thank you all.